Hi, good afternoon, everyone, and welcome to our webinar Wednesday. In today's webinar, which is a foundational lecture series on the HPO axis, or Female Hormones 101. My name is Amy Paoletti, and I'm a member of the Dutch education team, and I'd like to thank everyone for taking some time today to be with us. Real quickly, a few things that we're going to go over today, everything from A to Z about female hormones, fertility, PCOS, pregnancy, perimenopause, menopause, all the changes that a female, all those basic changes that a female goes through in her lifespan. Just a few housekeeping items before Dr. Hayes starts. We'll answer a few questions at the end if there's time permitting. And you can submit your questions through the question panel on the GoToMeeting panel. I just want to remind everybody, if you miss anything today or there's any technical difficulties we're not able to solve through chat, we will be sending the on-demand recording to everyone who registers, and even if you're on here live as well, tomorrow afternoon, probably within the 24-hour period time frame, you'll be getting an email from us with the recording and a copy of the presentation slides. And I actually may drag and drop the slides in before the end of the lecture today that you can download. So I'm going to get started here. I'd like to welcome our guest presenter today, Dr. Bethany Hayes. Dr. Hayes is a board-certified OBGYN and practiced obstetrics for 29 years, delivering her first baby in 1972 as a medical student at Baylor College of Medicine in Houston.
Hello, are you there? Well, that's not good.
Texas. She delivered her last baby in 2001 when she decided to put all her energy into Mid-Center Director of True Health, a nonprofit organization whose mission is to change healthcare in America, starting in Southern Maine. In 2016, True North closed its doors to patient care, but Dr. Hayes continued to compile the wisdom gleaned from this attempt to heal the healthcare system. Dr. Hayes has been a pioneer educator with the Institute of Functional Medicine, IFM, since 1999 and has been teaching for IFM since 2000 and is a past board member. Dr. Hayes was the proud recipient of IFM's highest honor, the Linus Pauling Award in 2008. Dr. Hayes received the award for her education and leadership in the field of functional medicine and specifically with the women's health issues. And Dr. Hayes was very integral in creating the curriculum for the hormone module that IFM teaches to this date. So without further ado, I'd like to welcome Dr. Hayes. Thanks, Dr. Hayes.
Thank you. I'm hoping that my audio doesn't cut out because it did just a minute ago. So if it does, yell in my ear and I'll stop until we fix that problem. So welcome to a little afternoon conversation about female hormones. I'll make one small correction. I'm not going to tell you everything about female hormones because there isn't enough time. And I'm going to try to finish within about an hour. And that usually means I'll run over. So let me start by saying I was a philosophy major in college, and so I'm going to start out with a little hormone philosophy. The philosophy is that when it comes to hormones, everything is connected to everything. So it may look like this ball of wire here and very confusing, but what that actually tells you is that everything is connected. And when you make changes in hormones, what you want to do is go slow and let the hormones readjust because the system will try to right itself. So when we interfere with hormones or try to fix hormones, we want to remember that this is a completely connected system and give it time to, okay, now my screen is not, oh, there it goes. Give it time to reassemble itself in a balanced place. So tell me again what the issue is. Do you want the simple but misleading explanation or the one you won't understand? Well, either one is good because I wasn't planning on listening. And I kind of wonder if when I finish a talk like this, if anyone is still listening. But I'm going to try to give you the simple explanation and hope that I don't confuse you too much, but I'm going to give you the 101 hormone talk, and then I'm going to take it up a layer to 201 where you'll get more information that will help you in your practice. And then I may add in some tidbits of information for people who have a lot of experience with this that may help get you out of trouble if you get stuck with a complex patient. So let's start with the definitions, where hormones come from and how they're controlled. Now, this is the basic definition of a hormone. This is what I learned in medical school. A hormone is a chemical produced by an endocrine organ which travels through the circulation and affects other cells at a distance. So it's something that affects cells at a distance. Female hormones are controlled and regulated by the hypothalamic pituitary ovarian axis, which is a feedback mechanism which allows the hormone to turn itself on and turn itself off. When a hormone can turn on and turn off, turn on and turn off, then it has more possibilities for dealing with changes in the environment. And the fact that the ovaries are connected to the hypothalamus, where all the sensory organs are also connected, allows us to see what's going on in the outside world, interpret that through our brain to the hypothalamus, direct the ovaries, and then the ovaries can respond to what's going on in the outside world. So hormones not only allow us to communicate from cell to cell, they also allow us to communicate from the outer world to the inner world. Premenopausally, hormones come primarily from the ovary, female hormones. Aromatase is found in the ovary, but not in the adrenals, and it converts androstenedione and testosterone made in the theca cell to estradiol in the granulosa cell. This system is connected to the hypothalamic pituitary ovarian axis. Postmenopausally, hormones come mostly from peripheral sources made in fat and fibrous tissue. So in the postmenopausal woman, the connection with the hypothalamic pituitary system is gone. The hormones are made locally and the control is local. So it's important to remember that, because premenopausally we can affect the system by changing hormone levels in the blood, and postmenopausally that's not where the hormones are coming from. They're coming from the peripheral sources such as fat. Progesterone is coming largely from the corpus luteum in premenopausal life. The corpus luteum is the site where the ovum is extruded from the ovary, and then those cells change to be able to produce high levels of progesterone. The postmenopausal woman also makes progesterone, but it's made in the adrenals. So you can imagine that if your adrenals are not working very well postmenopausally, your hormones may get out of balance. Testosterone is made both in the adrenals and in the ovary. So in this slide, this third white bar, I don't know if you can see my cursor, but the third white bar over here is the amount of testosterone made in a woman who's had her ovaries removed. So this is the adrenal contribution to testosterone. The remainder of the black bar, which is both adrenal and ovary, is the ovarian contribution. So you can see it's about 50-50. I'm going to talk a little bit later about what happens when the uterus is removed, but the ovaries are not. So what do hormones do? Well, hormones talk to each other. And this is a slide that I got from Jeff Bland, but it's the first time I really realized that, that female hormones talk to the immune system. In fact, women's immune systems are very different than men's, which is important in the time of pandemic, because women not only get COVID-19 less often, but they have a better outcome with COVID-19. However, they are also more likely to have autoimmune disease, and we're finding that some of the long-haul COVID people actually are suffering from autoimmune problems. This may come around to bite us with the vaccines if we find that the vaccine also induces some autoimmunity, but I don't think they're looking at the male-female ratio of side effects at this point. So why is this balance important? Well, everything needs to be balanced in a way that allows us to respond to changes in the environment. When the environment changes, the hormones will shift around until they can find a place of balance. If there's too much of a hormone or there's a missing hormone, then that balance tips, and when the system is not balanced, then we get symptoms. So in order to give our patients their best chance at health and longevity, we want to do our best to balance the system. So some people would then ask, well, if you're trying to balance the system, are there hierarchies of hormones? And in fact, this is the work of Diana Schwartzbein, who pointed out that there are hierarchies. She says that there are major and minor hormones. So these are the major hormones: adrenaline, cortisol, and insulin. And her definition of a major hormone is you lose it today and you are dead tomorrow. That would make you a major hormone. 2 out of 3 of these hormones are adrenal hormones, and only 1 is a steroid hormone and therefore participates in the steroid cascade or the steroid pathway. So the important thing here is that you can imagine that if 2 out of 3 of the major hormones are coming from the adrenals are going to be pretty important in terms of balancing the system. So let me just run through what these 3 major hormones do. High adrenaline, adrenaline is the fight or flight hormone, and we see a high adrenaline in people who are dieting, people who are over-exercising, people who are stressed from various reasons. And if adrenaline becomes your top hormone, it means you're young enough to tolerate adrenaline as your top hormone. But people with a high adrenaline are losing weight, they're anxious, they have hot flashes if they're high adrenaline at midlife. They have compensatory hypothyroidism. The thyroid is trying to turn down the heat that the adrenaline is producing, and it tends to make you cold. And they may have muscle wasting. Now, if you release adrenaline, you automatically release cortisol. So high cortisol people have usually been people who've been banging away at their adrenaline for a long time. And those people will eventually develop cortisol as their top or dominant hormone. These people will tend to be depressed. And if they still have a lot of adrenaline, they'll have an anxious depression. They tend to gain weight around the middle. They have frequent infections because high cortisol suppresses the immune system. They will have elevated cortisol, and they'll have any of the high adrenaline symptoms. So you can imagine if you have elevated blood sugars and your blood sugar goes up, but you're not exercising enough to get rid of it, that eventually you're going to end up with high insulin. But the problem with the adrenal hormones is that you need cortisol, but you really need it in the bank. You need it in reserve. So this is the way I explain it to my patients. You have an adrenal bank account. It's just like your regular bank account. You need money in the bank for a rainy day. If you have a problem that requires cortisol and you don't have any in the bank, you're going to get into trouble. The way you keep a reserve in your adrenal bank account is by depositing more than you remove. So removal has to do with things like eating inflammatory foods, getting an infection, being stressed at work, anything that tends to raise your cortisol level is going to spend your adrenal reserve. The probably only thing that puts a deposit into your bank account is sleep. So in my experience, if you aren't sleeping, you are not going to solve these problems. If you have a patient with adrenal fatigue or even type 2 diabetes, you're going to have trouble getting them balanced again if you can't get them sleeping. So you want to balance your deposits and your expenditures, and if you get overdrawn at the bank, it'll be just like if you're overdrawn at your a bank down the block. you're going to have symptoms. Now, high cortisol, as I said, will eventually lead to insulin resistance. So if your insulin becomes your top hormone, then you tend to be overweight everywhere as opposed to just in the belly. You have more trouble with inflammation, arthritis, skin rash, urge incontinence are common female symptoms. You develop syndrome X, and I think people who get syndrome X with insulin resistance are the people who get to insulin resistance through high cortisol. And you can, of course, have high insulin and still have high adrenaline and high cortisol. So when we're trying to solve these problems, remember that everything is connected to everything, and we have to think about the major hormones and probably try to balance them first before we go changing the minor hormones. Okay, so let me give you some more detailed information just to make it a little more confusing. Yes, I can make it more confusing. There are a number of ways that we can increase and decrease hormone levels. We don't have to, when I was training, you increased hormone levels by giving a FDA approved synthetic hormone, and we took it by mouth and the doses were really high. If we wanted to decrease the hormone dose, we removed the gland, mostly ovaries, but occasionally thyroids, almost never testes, and definitely not adrenals. So we now know that there are a number of ways that we can affect these hormone levels, both up and down, that do not require such radical types of interventions. We can increase the amount of function of the aromatase enzyme, for instance. We can increase the precursor of aromatase, which are the androgens. We can alter the gut microbiome, now called the estrobolome. We can induce more receptors and get a better estrogen effect. And there are 5 ways that you can decrease a hormone effect. You can remove the gland or tissue that makes it, of course, but you can also increase the metabolism and excretion to get rid of the hormone faster. You can block the production of the hormone. You can block aromatase. You can bind the hormone to its transport protein, sex hormone binding globulin, or you can modulate or block the receptors. So we now have a large group of approaches that we can take, many of which are gentle and safe to use and do not have some of the side effects that the more radical approaches that we used to take had. Now, one of the things that I've learned in doing this hormone project for many, many years is that if you want to create balance, it is a heck of a lot easier to do it if you use chemicals that are bioidentical, chemicals that the body makes, the body knows how to metabolize, the body knows how to use. If you use those chemicals, you're going to have a lot fewer side effects and strange outcomes that you weren't expecting. So I would say, given that we now have much better ways of getting bioidentical hormones into the system, there's almost no reason not to use them. Okay, so let's drill down into the 3 female hormones, estrogen, progesterone, and testosterone. Diana Schwartzbein would call those the minor hormones. I was a little bit offended by that, but she's probably right. So what are estrogens for? Well, obviously, estrogens are largely about creating the body that can carry a pregnancy to term and give birth and breastfeed. But that's not the only things that estrogens do. Estrogens also are involved with closing the epiphyses in both boys and girls. They help to create a bone structure that will support the extra weight of the pregnancy. And they help to prevent bone loss in old age that can lead to fractures and crippling and earlier death. Excuse me. Another thing that that estrogen does is it that affects and supports the specialization of the brain that allows a woman to mother an infant and breastfeed. So this slide said that a woman's brain shrinks during pregnancy and takes up to 6 months to regain its full size. I actually don't think that's a problem. I think it takes that kind of brain to be able to care for a newborn infant. And it's only a problem if you have to go back to work 2 weeks after the baby is born. The other thing that the estrogen does is it supports the brain in later life. So I want to introduce you to this person who is my mother. And she became a Unitarian minister at the age of 65. And here she is in the pulpit about 2 weeks ago, and she is currently 98 years old. Obviously, she has a brain that's working pretty well.
Dr. Hayes, can you hear me? So Dr. Hayes, we lost you on audio.
Estrogen good for the brain may also make it bad for the breast. It's a balancing act. So we need to remember that what we're trying to do with hormone interventions of all kinds is to create balance. So what does it take to be an estrogen? Well, these are all estrogen molecules. These are all molecules that engage the estrogen receptor. And you can see they look pretty different. What makes you an estrogen is this end of the molecule. It's called the phenylated A ring. And that A ring, that phenylated A ring, is produced by the enzyme aromatase. These are the 3 major estrogens found in the body. There are many other estrogen-like molecules found in the body, but these were the ones that they found in the highest amounts when they first started looking for estrogens in females. And what's important here is that there is estradiol, which is the major estrogen. It's takes very tiny amounts of this hormone to produce all the estrogen symptoms. It's a very powerful molecule. And it has precursors, estrone, which is a much weaker estrogen, and estriol, which is really a metabolite. And this is also a much weaker form of estrogen. Some things you need to know about estrogen are it comes from cholesterol. So if you're, I've seen medical students who were taking high-dose statin to keep their cholesterol levels as low as possible. And I wanted to say, ooh, wait, you're not going to have any of your steroid hormones if you bring cholesterol levels down too low. So it's probably a good idea to, if you have somebody who seems to have very low hormone levels, it's a good idea to check their cholesterol. Estrogen, estradiol, is down here kind of at the bottom of the back end of the steroid cascade. And it has a number of metabolites, and they're over here to the right of estradiol. This green arrow is aromatase, and it converts androgens to estrogens. So, important to remember that estrogens have positives and negatives. And what we're trying to go for here is balance. It inhibits bone resorption. That would be good. It improves lipid profile and improves endothelial function. That would be good. It stimulates the growth of bones and brain. That would be good. It improves vaginal lubrication and vaginal epithelium. Those are pretty good. It increases 1,25-dihydroxy vitamin D production, which in the time of COVID would be really good. It also has some negatives. It can be metabolized to a DNA damaging quinone. We're going to talk about that a bit more. It can stimulate the growth of breasts and endometrium, which after menopause we don't really want to have growing. It increases gallstone formation, and it induces proteins in the liver, which include binding globulins and clotting factors. So we're going to talk some more about that. Estrogen 201, so let's talk about this metabolism and a little bit about estrogen receptors. So estrogen is made with aromatase, green arrow here. And once you get to estrogen, this is a one-way arrow. Oh my goodness, where did that come from? Sorry, I don't know where that came from. I'm having a little computer glitch here. Shoot. I don't know what my computer is doing here. Fiddlesticks.
I don't know if hitting that side arrow, Dr. Hayes, over on your far right as you're looking at the screen, there's like that double side arrow. I don't know if that will close that window down.
Move. Oh, maybe that. Move.
Yeah.
Move.
Maybe.
Oh man. No, see, that's just, it won't go any further over. Boy, that's nuts. All right, let me, okay, wait.
There you go.
There.
There.
There, got it. Okay, computer. Oh. Okay, so let's go to estrogen metabolism. There are two basic steps to estrogen metabolism, phase 1 and phase 2. They occur in the liver. Phase 1 basically takes the estrogen molecule and makes it sticky. And it does that by sticking a hydroxyl group onto one of the carbon atoms on the molecule. And the enzymes that do that are the cytochrome P450 enzymes. And different enzymes will stick the hydroxyl group onto different places on the enzyme. But basically what it's doing is making the molecule sticky. Now, sticky molecules are, in general, not a good thing to have running around your body. They tend to get stuck on things. So the next thing that happens is you have a conjugation reaction that sticks something onto that hydroxyl group that makes it not sticky and water soluble. When it's water soluble, it can be excreted in both urine and the GI tract through the bile. So it's a two-step process. Phase 1 makes it sticky, phase 2 makes it water soluble. Now, with estrogen, you'll see this slide quite frequently because there are three main pathways that we're concerned with that estrogen hormones can go down to be metabolized and gotten rid of. The first is the 2-hydroxyestrogen here at the top. The second is the 16-hydroxyestrogen, and the third is the 4-hydroxyestrogen, which can become a DNA damaging quinone, but can also be neutralized by the second step, which is methylation. So what you often hear said is 2-hydroxyestrogens are good, 16-hydroxyestrogens are bad, and 4-hydroxyestrogens are really bad. In fact, all of the intermediates are not good, and all of the final products can be okay, if not good. So I don't like to call estrogens good or bad. I like to talk about what they do and why they're there. In any event, what you want to be sure happens is that they get conjugated. If any of these get conjugated, they're not a problem anymore. So it's only when you're making high amounts of the unconjugated hormone intermediates that you get into trouble with estrogen metabolism. So the main sources of conjugation are sulfates, glucuronides, and methyl groups. And I don't know where the molecule went on this slide. It's obviously AWOL. And we can measure these. We can measure them in urine, and this is the Dutch test, which gives you a really good picture of your progesterone, your testosterone, your androgens, and your estrogens and estrogen metabolism. And it gives you an idea of how the patient's estrogen metabolism compares to the normal ratio of the 2, 4, and 16. So when we look at female hormones, it's a good idea to take a look at these metabolites, because if you have someone who's making high levels of 4-hydroxyestrogen, you may want to make some adjustments before you add more estrogen to that picture. If you have someone who's making high amounts of 16-hydroxyestrogen, you might want to ask, what is the body trying to do here by making more potent estrogens? The 16-hydroxyestrogen is a more potent estrogen. Now, this is something I bumped into a while back, and I often hear this wrongly demonstrated. The cytochrome 1A1, which is the enzyme that makes 2-hydroxyestrogen. If you believe that 2-hydroxyestrogens are the good estrogen, you would say, well, yeah, wow, I want to have a lot of cytochrome 1A1. But if you go to the literature, cytochrome 1A1 is associated with a higher risk of breast cancer. So how does that happen? Well, it turns out that both 2 and 4-hydroxyestrogens are catechol estrogens. It means they have a hydroxyl group on 2 side-by-side carbon atoms. And it's that double hydroxyl group that can make the DNA damaging quinone. So both of these molecules can actually become DNA damaging quinones. It's just that the 4-hydroxyestrogen has a lot more affinity for the DNA than the 2 does. So you don't really see 2 making a lot of trouble unless the levels are really high. But I have had at least one patient who had really high 2-hydroxyestrogen genetically and ended up with breast cancer. So this is one of the reasons why I like to measure hormone metabolites before I start giving supplements like indole-3-carbinol or DIM, which increase the amount of 2-hydroxyestrogen. The other reason that this can happen is, if you notice here, the 1A1 and 1A2 primarily put your hydroxyl group on the 2 position, but look over here, they can also put it on the 4 position. So this might also explain why you might see someone with a really upregulated 1A1 producing some metabolites that you don't really want to have running around. Another thing you're going to notice is the 2-to-16 ratio has been rather extensively studied. And if you have a low 2-to-16 ratio, so low 2, high to 16, this is associated with increased estrogenicity and risk of estrogen-related problems. If you have a elevated 2-to-16 ratio, it's associated with decreased estrogenicity, but could be associated with osteoporosis if you have someone with really low estrogen levels. Now, what's interesting is that these ratios will shift. They don't always stay the same, even in the same patient. So if you have a patient who's premenopausal and there's a lot of estrogen around, she may have a high 2-to-16 ratio. Her body is trying to get less potent estrogen metabolites. If she suddenly goes through menopause and her estrogen levels drop, the body's going to try to rebalance by increasing the 16 and decreasing the 2 in order to give her more estrogenicity. So if you give estrogen, you may see this 2-to-16 ratio shift. And what you should do about that is think about, is the body trying to tell you about how much estrogen it wants or needs at that particular time? Now, the other thing that's difficult about estrogen metabolism is that after menopause, it occurs out in the periphery. So this is what I call the estrogen factory in the breast. These enzymes occur in the fat cells in the breast, and they make estrogen. And all of the ones that are circled here are associated with a higher risk of breast cancer. So the breast is a unique organ in that it is an estrogen-sensitive organ sitting in the middle of an estrogen factory. And we don't have really good ways of accessing what's going on at the level of the breast. That would be great if we could get tissue levels of hormones, but women are not too good about wanting you to take pieces of their breast. Another important thing about estrogen metabolism is that there's a third step, and that is the excretion step. So if you're excreting it in urine, you want to stay well hydrated. If you're excreting it in the gut, you want to have a healthy microbiome with bacteria that don't make high levels of beta-glucuronidase. Beta-glucuronidase basically pops the glucuronide molecule off of your estrogen, and then it's no longer water soluble, and your body reabsorbs it in an enterohepatic circulation that can raise hormone levels. So ways to inhibit beta-glucuronidase are a really good way of handling estrogen. You also want fiber, because fiber binds these hormones and helps take them out the back door. You want to have good bowel function. So before you start messing around with hormones, make sure that your patient has a healthy microbiome and takes out the garbage every morning, has good bowel function. Alcohol can inhibit the liver metabolism of estrogens, and high amounts of estrogen going through the liver, remember, produce high levels of binding globulins. They can interfere with, or drugs and toxins can compete for the enzymes that you need to metabolize your estrogens. And yeast is sort of interesting. The yeast in the GI tract actually make some mycoestrogens, and they also make alcohol, which inhibits the metabolism of estrogen. So these are all important gut effects on estrogens that are important to pay attention to, and don't leap immediately to giving the hormone if some of these other problems can be fixed. So this is I call it sometimes phase 3 metabolism. It is the excretion phase. And my favorite supplement here is calcium D-glucarate, which inhibits the beta-glucuronidase. And it's a really great way of getting rid of extra estrogen without changing either the production or distribution of estrogen in the tissues. So it's a really great supplement for people with high estrogen. The final thing I want to say about estradiol is it's probably hormetic. And something that's hormetic means that in the high amounts, it has a bad effect, but in low amounts, it may have a good effect. So it's the opposite of what you'd expect. Normally, you expect that a drug or a chemical will have an increasing effect the more you give, but in a hormetic chemical, a small amount is a good idea. It can have very different effects than a large amount. So with estrogen, we know you can have too little. You can have women who've had their ovaries removed and their very low estrogen levels can throw things out of balance, but you can also have too much in the middle. So there's been some debate about whether estrogen can cause cancer or cause breast cancer, but there are 3 things to worry about in that realm. First is that estrogen is mitogenic, and with age, it can cause the cells to divide before the DNA damage can be repaired or before apoptosis can occur and shut down an abnormal cell. The second way it can affect cancer is when it's metabolized to the 4-hydroxy DNA adduct that we just talked about. It damages DNA. So this can happen in cases of cancer or endometriosis. And Eleanor Rogan believes that this is a common and significant cause of breast cancers, also prostate cancer. And third, estrogens may affect some processes in the mitochondria that we know are involved in creating cancer cells. Estrogen has a role in the Warburg process, in which cells use sugar to make energy rather than using the electron transport chain. So estrogen is an important molecule. It's very powerful in very small amounts, and there's some downsides to having too much of it around. Estrogen receptors, wow, more and more complex. So estrogen receptors are dimers. You can see there are two sides, the red side and the green side, that are holding on to the ligand, the estrogen molecule, and they then find their way to sit on specific estrogen response elements on the RNA, which is this stuff down here.
Hey, Dr. Hayes,
because there are E alpha alpha, beta beta, or alpha beta, you've got lots of options. What? Yes.
Yeah, real quick,
yes.
We are having just a little bit of
yes.
audio. I don't know if you're moving around or anything from the microphone, but we're having just a little bit of audio in and out.
No, okay.
Okay, just to keep it.
Okay, I'm sorry. Maybe it's.
No worries.
I can try something different. Nope, that's not going to work. Shoot.
Keep going. Let's see if we can keep
okay,
it.
I'll try not to move around too much.
Okay, thanks.
Okay, sorry. Okay, so estrogen receptors allow cells to have lots of options for how they use the estrogen molecules. Estrogen receptor alpha tends to be in certain organ systems, whereas beta is in other organs. And the selective estrogen receptor modulator is a whole science that has been created to try to take advantage of this and get estrogen effects that you want in different organs. Now, there are also naturally occurring molecules that can affect estrogen alpha and estrogen beta, and this is a kind of an interesting slide that shows you that estriol and some of the soy products, genistein, coumadin, and daidzein, are estrogen receptor beta stimulants primarily. But these are not the only way that estrogen interacts with cells, and so here are literally 5 other ways that estrogens can interact with cells other than the steroid receptor in the nucleus. The important thing to understand about that is some of these things take a long time, and some of them happen pretty fast. So when hormone levels are changing, you can get unbalanced estrogen function. You can get some of the estrogen functions come on board immediately, and others take hours or days to come on board. That can produce some pretty unpleasant symptoms. So women often have symptoms when their estrogen levels are changing rapidly, both going up and going down. And then I ran into this. These are the estrogen-related receptors. These are receptors that look pretty much like estrogen receptors, but estrogen is not the ligand. You don't find estrogen stuck to these receptors. They act like estrogen receptors. They affect enzymes like aromatase. They affect the estrogen receptors do affect the amount of these ERRs or estrogen-related receptors, but they don't know what the ligand is. They don't know what's stimulating these receptors. So this is another whole area of intrigue about how estrogens work, and I wonder if some of these ligands aren't going to turn out to be estrogen-like molecules in the environment, the endocrine disruptors. So speaking of endocrine disruptors, they're everywhere. We have them in our bodies, we have them in our food, we have them in our air, we have them in our water. They are increasing dramatically everywhere. And they are significant disruptors of body function. And I think when we think we know what we're doing, testing and giving hormones, we need to remember that there are a whole bunch of estrogen-like molecules that we're not testing for at all and have no idea how they're affecting us. They may affect the synthesis of hormones. They may block or bind hormone receptors. They may alter the amount or activity of hormone receptors in target tissues. They may change signaling cascades, and they may alter hormone metabolism. Excuse me. And finally, it's important to remember that women who are overweight have a lot more fatty conversion of androgens to estrogen, and this becomes important after menopause, because remember, most of the estrogen is being made peripherally in fat tissue. Also, insulin resistance can increase androgens, which will lower sexual hormone binding globulin, releasing estrogen into the environment. And dietary preferences that make you obese also can alter the gut microbiome. So this is one of the reasons that obesity is associated with estrogen-related cancers. So we've sort of blown through a whole flotilla of ways that we can modulate estrogen. So these are the points at which we can change hormones in people without using radical approaches like synthetic hormones or ovarian removal. So let's talk about progesterone. Estrogen is the easy one. So this is some of the functions of progesterone. There are really a lot of functions of progesterone. And when I began getting interested in progesterone, because there was so much controversy about it, I was really quite surprised to find how many things estrogen did besides just being a progestational hormone. So this is its primary goal. It comes from the corpus luteum, and it supports the pregnancy until the placenta can take over the production of progesterone. The problem is if you have a corpus luteum that's not working well enough and it begins to fall off before the placenta takes over, you get a dip in progesterone here, the uterus gets irritable, and the mother miscarries. So this happens on about day 44. I had a patient once who came in and said, I'm going to miscarry next Thursday. I said, really? She said, yes, I always miscarry on day 44. I said, how many times have you miscarried on day 44? She said, 3 times. I said, wow, okay. The only way that can happen is if you have a luteal phase defect. And so what we're going to do is give you progesterone and you're going to carry the pregnancy. And we did, and she carried to term. So progesterone is an upstream hormone. It's way up here with pregnenolone. And so when you put progesterone into the mix, you have no idea whether it's going to go down or over and down or all the way over to estrogen. And so progesterone is these upstream hormones, pregnenolone, progesterone, and DHEA, can potentially give you effects that you're not expecting. If you give someone progesterone and you get cortisol effects, you've got all of these enzymes to cortisol turned on, and you've got a person who's stressed out. What you need to do is deal with the stress and then give the progesterone again, and you'll get progesterone that balances your estrogens. So remember that progesterone is an upstream hormone. In addition, if everything is going to cortisol, you are going to see something called cortisol steal, in which everything goes to cortisol and progesterone levels fall. Sources of progesterone in the premenopausal woman are primarily from the corpus luteum. So as you approach menopause and your ovaries forget to ovulate more often, you will see falling levels of progesterone. After menopause, the estrogen levels are low and it doesn't take a lot of progesterone, so the amount produced by the adrenals is adequate to balance estrogens. However, if you have someone whose adrenals are not functioning well or they're under a lot of stress, then they can end up with inadequate amounts of progesterone to balance their estrogens. So progesterone has been difficult to study, in part because we haven't been very careful about how we refer to chemical versions of progesterone. As I said in the beginning, when I talk about progesterone, I mean bioidentical progesterone. When I talk about the chemical artificial progestins, I refer to them as progestins or synthetic progestins. And they actually do very different things than bioidentical progesterone. This is a study that looked at what genes are turned on by estrogen and progesterone, the big circle over here on the left, estrogen and MPA, the circle to the right, and estradiol alone. And as you can see, there is not a lot of overlap between between progesterone and MPA, methoxyprogesterone acetate, or synthetic progestin. Plus, there are a lot more genes that are being turned on by bioidentical progesterone, and I think we need to know a lot more about what those genes are doing. Bioidentical progesterone also makes metabolites such as allopregnenolone that are GABA receptor agonists. So when you're making a lot of progesterone, like in the luteal phase, it helps to deal with some of the irritability that estrogen causes in the brain. If you pill and you have artificial progestins but not progesterone making allopregnenolone, you can get very irritable or even depressed when you're on the birth control pill. You have estrogen but you don't have progesterone to balance it. If you want to get more of that effect, you can add progesterone, and it's okay to, I think it's okay to add progesterone even if you're on the pill. It's sometimes takes care of that irritability problem. But if you want to get a progesterone metabolite effect, the best way to get it is by giving progesterone by mouth, because then you get first pass through the liver. Most of the hormone is metabolized into allopregnenolone, and you get that brain calming effect. You should probably tell people not to operate heavy equipment until they know how it's going to affect their brain. And I tell them to take it at bedtime because it's a pretty good soporific. Now, this is an old study, but really interesting because initially we thought that all progestogens were alike. So artificial progestins were the same as progesterone, and they made it initially to affect the endometrium. And so they were surprised to find out that that bioidentical progesterone really didn't have the same effect on the breast that it did on the endometrium. So here is looking at gland mitoses. You can see that gland mitoses go up dramatically in the follicular phase of the cycle and then fall off in the luteal phase. So that's the endometrium. So progesterone makes the endometrium grow, and then it stops growing and decidualizes. In the breast, it's the exact reverse. You see not much going on until you reach the luteal phase of the cycle, and then mitoses increase dramatically. Oops, these are glands. Mitoses increase dramatically, and then with progesterone withdrawal, the gland mitoses drop off and the gland involutes. So this is a big difference between how progesterone functions in the endometrium versus how it functions in the breast. Well, progesterone also has receptors, and the thing that you need to know about progesterone receptors are it takes estrogens to stimulate the expression of progesterone receptors. If you don't have estrogen, you are not going to have cells that can hear progesterone. They're not going to have progesterone receptors. So if you're giving just progesterone for, say, hot flashes, and you don't have enough estrogen around, you're not going to get much effect from that progesterone. If you have an effect from the progesterone, it automatically means you've got estrogen around, and maybe you need to look for another reason for your hot flashes. Progesterone suppresses the expression of estrogen receptors. So progesterone turns off estrogen. It's part of that ability to turn things on and off so that you can both keep things from overgrowing and also have more flexibility in the system. So this is going to be hard to do without my notes, but one of the difficult things about progesterone and the question of does progesterone, is it good or bad for the breasts, is that it's very difficult to study progesterone. It has to do with that issue of does estrogen, do estrogen and progesterone function always together? Can you study progesterone without studying estrogen? So this is the PEPI trial, which I went back and looked at after the Women's Health Initiative. And what it showed, this circle got moved, is that estrogen plus micronized progesterone caused the most breast discomfort. And I took that as a surrogate for stimulation of breast tissue. So I was quite concerned about that. Then the French E3N study came out, and many people said, oh, yay, this shows that progesterone doesn't do anything bad to breasts because the relative risk for progesterone was 1, meaning it had no increased risk of causing cancer. Of course, it was not statistically significant. And I looked at that and I said, wait a minute, there's more going on here than just it has no effect. It has an average effect of no effect, an average effect of 1, but in fact, initially, when you start taking hormone replacement, which is immediately after menopause usually, it actually decreases the risk of breast cancer. And then as you get farther and farther out from menopause, the risk starts going up until you get out to about 4 to 6 years where the progesterone increased the risk of breast cancer, just like estrogen alone, and just like dydrogesterone, and even worse in the synthetic progestins. So I think this study suggests that the issue here is not that progesterone is totally safe to give. It's that what matters is the amount of estrogen that is accompanying the progesterone. And then I came across this article that said after menopause, however, a mitogenic effect of progesterone becomes apparent, which may be due to the reduction in endogenous estradiol levels, or possibly due to tissue-specific alterations in steroid sensitivity. But this was the first time I read something that explained the E3N study for me. Then I found this brilliant piece of work, which was a study in mice, I think, mice that they tricked into being able to look at progesterone without estrogen effects. They tricked the cells into functioning, having progesterone functioning without estrogen. And basically what they found was that the effect of progesterone was neither inherently proliferative nor anti-proliferative, but that its effects on growth depended on whether the treatment was transient or continuous. The former, transient, meaning cycled, stimulates cell cycle turnover, and the latter inhibits it. And that went along with some early work that shows that initially adding progesterone stimulated growth. Then with time, it inhibited growth and eventually produced differentiation. So my take on this is that when estrogen levels are high, progesterone inhibits cell proliferation in the endometrium by inducing luteal phase decidual changes. So we know that's what happens in the endometrium. In the breast, when estrogen levels are high, continuous progesterone, think pregnancy, which prepares the breast for lactation and can cause breast tenderness. When estrogen levels are high, cycling progesterone decreases the breast cancer risk. Think what happens in perimenopause or in the early menopausal phase. You want to continue cycling progesterone. But after menopause, progesterone gradually it comes from the adrenals and gradually increases the risk based on what the amount of estrogen is. So higher amounts of estrogen require higher amounts of progesterone, and given continuously can increase breast cancer risk. When estrogen levels are low, adding cyclic progesterone may increase breast cancer risk, and you should give low levels like the adrenals and give it continuously. So progesterone has positives and negatives. It lowers estrogen effect, it's brain calming, it decreases menstrual flow, it improves bone density. It has negatives. It provides precursors for cortisol and aldosterone, which you may not want to have a lot running around. It's difficult to get luteal phase levels. It's difficult to measure. It's complex in relationship to breast cancer. So let's talk about testosterone. So I showed you this slide earlier. And the interesting thing here is you tend to see in the literature that if the uterus is removed but the ovaries are not, they consider that to be a normal testosterone level. But as you can see here, there's a rather considerable drop in testosterone levels by simply removing the uterus without taking the ovaries. So I think the reason that happens is when you remove the ovaries, when you remove the uterus, you clamp the uterine ovarian ligament and destroy some of the circulation to the ovary. This can also happen with tubal ligation. But in general, in normal women who are not surgically menopaused, the testosterone levels go down slowly, just exactly like they do in men. And what that tends to mean is while there is a sudden drop in estrogen at menopause, there is not a sudden drop in testosterone. And that leaves women with a period of time around perimenopause where they have higher levels of testosterone relative to the amount of estrogen. Now, in men and women, testosterone levels are associated with adrenal stress. So here is the cortisol steal situation. You've got pregnenolone and progesterone that that go downstream and build cortisol, draining progesterone. Following which, if you continue, you can also get lowered levels of the downstream molecules, DHEA, testosterone, and estradiol. So remember that when the adrenals are not functioning well, you get too much cortisol and not enough of almost everything else. Now, DHT is the end point of testosterone, and it is the active form of testosterone. It's very potent. It causes hair loss, and one of my colleagues says that if you see hair loss in women, they always have elevated DHT. It's an irreversible pathway, so if you've got an upregulated 5-alpha reductase, you're going to have a lot of DHT and have trouble getting rid of it. And there are inhibitors of DHT, which include saw palmetto, beta-sitosterol, and finasteride. So testosterone levels spike at ovulation, and I think that's to help you get pregnant. And again, a little bit before menses, and that's to keep you married. And they spike a little bit in the morning, but not like they do in men. So men tend to think that that everyone should want to have sex like they do, but in fact, women want to have sex at ovulation, maybe a little bit before their period. And then the rest of the time, what we're interested in is relationship. So my rule is the person with the most testosterone is in charge of getting the other one interested. Because levels in women slowly decrease at menopause, healthy women have a period of estrogen testosterone balance that favors testosterone. And for healthy women, this is accompanied by increased sexual desire and probably a little more aggressiveness. Testosterone affects sex hormone binding globulin in the opposite direction. So high testosterone lowers sex hormone binding globulin and releases both testosterone and estrogen. And so you can use testosterone to get better estrogen effect while giving smaller amounts of estrogen corrected to improve sex hormone binding globulin effect on estrogen. So We used to give testosterone to get a better effect of estrogen on vulvar and vaginal tissues. I suspect what we were getting was a systemic effect on sex hormone binding globulin. So women identify many reasons that they are sexual over and beyond inherent sexual desire or hunger. Women tell of wanting to increase emotional closeness, commitment, sharing, tenderness, and tolerance, and to show the partner that he or she has been missed emotionally or physically. Women want relationship, men want release, and we tend to misunderstand each other. This is a good article to read before you treat sexual dysfunction in women. Sex hormone binding globulin, I actually keep this slide in a drawer in my desk because when I see a sex hormone binding globulin level that's either too high or too low, I want to go and look at what hormones may cause increases or decreases. And so this is a list. It's a little complicated, but basically things that increase sex hormone binding globulin include estrogen, pregnancy, and certain drugs, and thyroxine. And things that decrease include testosterone, insulin, growth hormone, prolactin, cortisol, progestin, some of the things that we know increase the risk of breast cancer. So the ideal range in blood, and this is total testosterone, is 0.25 to 0.4 nanograms per milliliter. Remember, testosterone is a precursor for estradiol. The converting enzyme is aromatase, which can be affected by many supplements and plants substances. Testosterone levels correlate with breast cancer risk, probably related to their effect on sex hormone binding globulin, but androgen receptor function is also a complex issue in breast cancer. There's also a bioidentical issue in testosterone. Men were basically stopped using methyl testosterone because it caused liver tumors. They kept giving it to women for several years after that, but there are now options of bioidentical testosterone for women. DHEA is thought by some to be more than just an androgen precursor. Receptors for DHEA have been found in the brain and bone, and the person doing the most research in this area is Labre, and I have not been a big fan of this because epidemiologic studies have shown correlations between DHEA and breast cancer. And remember, the estrogen factory in the breast includes DHEA, which produces more of the androstenedione that produces both testosterone and estradiol. So let's talk quickly, because I'm running late, about the stages in a woman's life. We start out with pretty low hormone levels, and then they get kind of crazy, and then you begin to have regular ovulation, regular testosterone, things settle out. You may have a pregnancy during this period, and then the eggs begin to run out, and you begin to have the brain trying to get those last few eggs out of the ovary. You actually get an elevation in estrogen with a decrease in progesterone. So this is the period when you'll have estrogen dominant problems. And things get pretty squirrely. Hormone levels can be high or low or in between. And at some point, the amount of estrogen is not sufficient to produce a period. And at that point, we call it menopause. However, you can see that the hormone craziness continues for quite a bit after that until it finally gets down to a calm level out here somewhere in older adulthood. Then it gradually drifts downward until we get to very old people. Now, a lot of people think that this means that older women are hormone deficient and they should be returned to premenopausal levels of hormone because, hey, old people are not healthy, but 30-year-olds are healthy. And my answer to that is, are 30-year-olds healthier or less healthy than 10-year-olds who have exactly the same hormone levels that the older folks do? These people just have cells that have accumulated more damage. So this is a graphic representation of the last 100 months of a woman's menstrual life. And the things to notice here are, yes, the black lines are skipped ovulations, but with periods that happen. The tall lines are periods that didn't happen or were delayed, but maybe ovulated at the end. And here's one that went several months and then ovulated. And the thing to notice here is that although these last periods were a little squirrely, the last two were both pretty normal length and ovulatory. So don't count on you can't get pregnant at the end of this perimenopausal period. This is a wonderful piece of work done by Jerry Lynn Pryor, and she basically teased out the phases of perimenopause. She tells you about how long they last, what your cycles are like, what the flow is like, what kind of symptoms you have, whether you're having hot flashes and what they look like, and what the hormone levels look like. And this is another thing I keep in a drawer by my desk. The important thing to know about perimenopause is you have estrogen dominance. So estrogen levels are higher than normal, but progesterone levels are lower than normal. So when someone comes in perimenopause and they're having hot flashes, their problem is not low estrogen. You don't want to give them more estrogen. Their problem is probably too much adrenaline, or their problem is the change in hormone levels. So too much estrogen can produce this kind of problem: breast tenderness, headaches, mood swings, heavy periods, endometriosis, growth of fibroids, all the things that we see in perimenopause. So the treatment is to help metabolize estrogen and get rid of it faster, and give progesterone to balance the estrogen effect. Menopause occurs on average at the age of 52. It's defined retroactively. You have to go a full year with no bleeding, and then we'll tell you you went through menopause a year ago. That's because the hormones are so squirrely that you can have periods that show up late. And if we went after every single one of those as a postmenopausal bleeding episode, we'd be doing endometrial biopsies on everything that moves. So we wait a full year before we call it menopause. Then if you bleed after that, we call it postmenopausal bleeding. It's accompanied by a lot of symptoms. Some of those symptoms occur early, and some only occur after long periods of time. And they're often thrown into one bag of menopausal symptoms. So I think it's really important to pay attention to, are the dominance or late menopausal symptoms, which may be estrogen is a deficiency. And there's an ongoing debate as to whether menopause hormone deficiency state hormones should be replaced. And I think that largely came about because when we first started studying hormones and giving women hormones, we had a different population of women. They were women who had largely had hysterectomies, and most of them had their ovaries removed. We had trouble giving bioidentical hormones because we couldn't get them on board. And so we were giving artificial progestins and conjugated equine estrogens, which gave us a whole lot of symptoms that we can avoid by giving bioidentical hormones. So now we both can get bioidentical hormones into the system, and we are dealing with a different population of women. So I think what the conventional world is now doing is calling it hormone therapy instead of hormone replacement therapy. But if you have people whose hormones are below normal for their age and you are replacing it, I think we should continue calling that hormone replacement therapy. This is also Jerry Lynn Pryor's work, and what I love about this is that she talks about perimenopause and menopause, and then older women, and then frail women. So she's dividing menopause into 3 stages: early stage, middle stage, and late stage. And when I began looking at replacing hormones to normal for age, I couldn't figure out what normal for age was, so I had to do a lot of research, and ultimately I came up with this graph, which I would divide into the same 3 areas. Early, when estrogen levels are really pretty high; mid-stage, when estrogen levels are low but not problematic; and late, when estrogen levels really become deficient. And my definition of deficient is below 10 picograms per milliliter. So I try to return women to 10 to 30 picograms per milliliter. This is nanomoles over here. This is the 10 picogram per milliliter. Because that's what Mother Nature would be doing, and I will bring the levels up to as much as 30 picograms per milliliter to get in this range. But you can see, if you remove ovaries, you're taking a lot of hormone years away from women, and we've pretty much found out that that's a bad problem. A lot of people say that that's not enough hormone to keep bones safe. I've heard people say that you have to have luteal phase levels of estrogen to get bone mineral density healthy, and I think that's wrong. This is a study by Ettinger that shows you can raise hormone estrogen levels with very small amounts of estrogen to almost to 10 picograms per milliliter and see bone mineral density go up. Okay. Ovarian status can vary with natural menopause, with surgery, and with autoimmune destruction of the ovary. Estrogen is hormetic, and therefore too little or too much is problematic. And hormone replacement is, well, complex. So I think there's a tipping point between the positive and negative effects of estrogen, and that's what you're trying to find. You're looking for that point because that's the point that creates balance. Now, in order to get to that point and be asymptomatic, you may have to deal with adrenal problems, with nutritional problems, with sleep problems, and we should be doing all of those things. The autoimmune issue is interesting because there is now thought to be not only premature ovarian failure, but also polycystic ovarian syndrome, infertility, and endometriosis that may be autoimmune related. And I found this interesting study, which said at age 20, the incidence was 1 in 10,000, and then by 30, it's 1 in 1,000, and by 40, it's 1 in 100. So I guess by 50, it's 1 in 10, and by 60, everyone has got it. I don't know. But it makes me wonder how much of menopause is actually autoimmune destruction of the ovary. Well, one way you can try to diagnose that, because there aren't any ovarian antibodies you can test for except in experimental labs, because there's so many different proteins in the ovary that you can have antibodies to. But one way to look at it is, if you have autoimmune destruction of the ovary, it's not going to be making as much testosterone. So women who have ovaries but are not making enough testosterone are either have adrenal fatigue with testosterone steal, or they have autoimmune destruction of the ovary. Okay, so this is a single slide hormone replacement slide. So if you came for a talk on hormone replacement, I'm really sorry you didn't get that. But these are some things that I learned from knowing all that other stuff in terms of how I give hormone therapy. So the first thing is to look for the correct hormone to replace. Don't replace something that's not broken. Use bioidentical and preferably transdermal hormones. We didn't talk a lot about that, but you really don't want first pass through the liver. Start low and go up slow. Let the body adjust slowly. And I let patients control that by giving hormone drops, starting low and letting them go up very slowly until they feel the way they want to feel, and then we double check their hormone levels. So I get lab tests when I need to check for ovulation, when I need to know the baseline status before hormone therapy, when I want to be certain of hormone metabolism, when I need follow-up after therapy, and then I check again between 60 and 65 to reevaluate whether they need to continue therapy. So what labs to get? I'm going to whip through this kind of fast. I don't use salivary hormone. I found this graph, which is 3 months of an ovulating woman's salivary estradiol level, and it looks like mishmash to me. If I got a level right here, I wouldn't know where I was in the cycle. I wouldn't know if she was ovulating. I wouldn't know if she had normal levels of hormone. This is really fantastic work that Mark has done with the Dutch lab folks, and what he shows here is this is the serum estrogen, this is the ovulatory spike, and the progesterone response. So that is a normal menstrual cycle. All the rest of these are the same woman on the same month of her cycle. This one is urine, and you can see you get a good estrogen spike. It's in the same place as this one, and the progesterone looks pretty much like this, although there's a sort of a double hump here. It has to do with metabolism. And then you get the salivary hormone levels. So when did this woman ovulate? You know, the only way you could tell is what's going on with progesterone here, but why is estradiol doing this? And then in these other labs, all salivary hormone labs, almost none of them got hormone levels above the menopausal level. The purple line is normal menopausal level of hormone. So I just have not found salivary hormone levels in estrogen and progesterone at all useful, and I don't use them. I do use salivary hormones for cortisol, although now the Dutch people have come up with some spot tests for cortisol that seem to be working pretty well. So you do hormone assessment when it doesn't look like the hormone you think is causing the problem is actually causing the problem. So don't treat hot flashes with estrogen if this is the problem. You also want to use hormone levels when you're giving hormone therapy. You get tests before and after. Use hormone levels when you're confused, when it's not making sense. Get more information, and you can use hormone levels to find out if ovulation is occurring, and you can use hormone levels to just map the whole picture and see where the blocks are, what enzymes are working, what enzymes are not working. Sometimes teaching yourself a little steroid hormone pathway and asking where are the blockades and why will teach you why some of your lab tests are not correlating with what's going on with your patients. And as I said, I think it's really important to evaluate estrogen metabolism before you start trying to adjust to get good estrogens or bad estrogens. And finally, it's important to use hormone testing because I don't think we've been doing it enough. So much of the literature that I read doesn't include hormone levels. And so I don't know how we thought we knew anything about what was going on with women in perimenopause and menopause when we weren't checking hormone levels. And I think it's getting easier to do that. It's getting less expensive to do that. You can do it at home with urine testing. And I know this sounds like an advertisement for Dutch, but hey, we should be doing a lot more hormone testing. So don't miss the obvious because you're not used to doing hormone testing. Do some hormone testing and teach yourself about women's hormones. Okay, well, I apologize for all of the glitches and not having the right microphone and not being able to read my notes. So I hope this made some sense to you. And I'm sure if you want to send in questions, Amy can send those along and we'll try to get you answers.
And that's exactly what I'll do. We've got some really good questions here, and I'll send them on to you. And everybody, we will try to get those answers back out to you or back out to the group that listened to us live today to get all of these answered. Overwhelming response on how many people love that slide that you showed with Jenny Lynn Pryor's information on the stages. That's an awesome slide. Yeah.
That's a great slide. It's very helpful, and I found really very accurate. She is dynamite. I ran into her at a functional medicine meeting one day. I was so excited to meet her. She's like a heroine of mine. And now she's done this really interesting article on progesterone and bone mineral density. And she really believes that what happens to progesterone in perimenopause sets you up for
Osteoporosis.
bone loss,
Bone
osteoporosis.
loss. Yeah.
And the other really interesting thing out there about osteoporosis is a comment that Joe Pizzorno made about how we store heavy metals in our bones. And then when we go through menopause and we suddenly start losing bone, we lose those heavy metals into the circulation. So I always thought that maybe the brain problems we get at menopause are actually toxic minerals coming out of our bones. So it's important to try to keep those bones appropriately calcified and functioning normally with normal breakdown and buildup.
Absolutely. All right. Well, thank you, Dr. Hayes, for being with us today. We really appreciate it. This was a great presentation. Thanks, everybody, for joining us. Again, I'll be sending these questions to Dr. Hayes. We'll try to get all of the information out to the group. Once again, you will get the recording and a copy of the slides tomorrow. And again, I want to thank everybody in April. Be on the lookout. We've got Dr. Tara Scott, who will be our guest presenter in April, and look forward to having you all join us again. Thanks again, everybody.